was actually launched in US, but then it lost its place because of lot of confusion, because of concerns regarding metabolic acidosis. Kindly keep decorum. Kindly keep decorum. It lost its place because of concerns, misplaced though, on issues of metabolic acidosis. And I remember when I was doing diabetic clinic in Saptarshi hospital during my post-graduation in senior residency, we were writing a molecule called fenformin. It used to come with the brand name DBITD. And they said that fenformin is actually a molecule which causes more lactic acidosis than metformin. But we were writing more DBITD because it was available in the hospital. Then we came face to face with newer sulfonylureas, glycoside, and longer acting sulfonylureas, glimepiride. And then we started getting multiple combinations of metformin and sulfonylureas. What happened? Tolbutamide and chlorpropamide disappeared from the scene. So we had either metformin plain, or we had metformin and glimepiride, or metformin, glycoside. We used to get a wonderful molecule called dimacron XR, and then the various combinations with it. Then, until about 2000, there was nothing new which came apart from the AGIs, alpha glucosidase inhibitors, and the first one that was launched was acarbose, and then the ones with lesser side effects, the voglibos. Okay. But in 2005, we very seriously started thinking in terms of the other aspect of metabolic control in diabetes. It's not only about insulin, it's also about glucagon. So in 2007, we had the launch of sitagliptin in India. Okay, a molecule which was impacting pancreas, but both beta cells as well as alpha cells. So it was not only causing insulin release, but it was also causing decrease in the glucagon levels. From 2007 till 2015, we did not have any molecule, whether it was metformin, glimepiride, or DPP-4 inhibitors, which made significant difference to the macrovascular complications. Okay, you remember the trial from 1997 to 2007, 1977 to 1997, and the follow-up period of 10 years till 2007 of UK PDS, which told us that there were remarkable developments on the front of microvascular complications, but there was not much on macrovascular complications. For the first time in 2015, we had this wonderful, remarkable molecule, a range of molecules actually, but the first one to be launched was in India, the empagliflozin. Okay, the empagliflozin. And the EMPA-RAG trial bridged this micro and the macrovascular gap. We had wonderful benefits on the macrovascular front. But was there something else to be achieved? We were still watching only insulin and glucagon. There was another aspect in diabetes, and that was obesity. बहुत ज़्यादा लोग उसके बारे में वरीड नहीं थे, उसको मजाक लेते थे, है ना? लाला जी तुम किस चक्की का खाते हो? इस डेट छटाक के राशन में भी तोंद बढ़ाए जाते हैं। आराम शब्द में राम छिपा, जो भव बंधन को खोता है, आराम शब्द का ज्ञाता ही तो बिरला ही योगी होता है। और डॉक्टर किरण पोदार को पूरी की पूरी कविता याद है, कमाल की बात है। बट कमाल ये है कि इसके बियॉन्ड हम कभी गए नहीं। And then we very seriously started thinking in terms of obesity as a parameter, as a facet which we need to address. Okay, and therefore we started getting lot of molecules which were addressing this issue. Believe you me, the next 5 decades in diabetes management are only going to be about weight in diabetes or weight without diabetes. If you change the name of your clinic to weight loss clinic, you have to do nothing else, I can assure you. I am telling you, The secret of medicine. Change with the times. Dr. Chauhan Polyclinic. No. Dr. Chauhan's weight loss clinic. डॉक्टर आंख से देखो वजन कैसे कम होता है. Okay, so today we have molecules one after the another which are causing weight loss and giving wonderful CV outcomes, not only microvascular, also macrovascular. And therefore we have two wonderful speakers today who are going to speak on these two molecules, on one molecule, actually it's injectable Semaglutide 2.4 milligram. Although it has been approved for use, the Ozempic 1 milligram for use in diabetes only, but we have 2.4 milligram Semaglutide which has been approved for weight loss, and there have been multiple trials called the Semaglutide treatment in people, STEP, okay, in people and in obesity, without obesity, and multiple combinations of that, and STEP 1 to 8, okay. There must be more, maybe I'm missing out on some, and they will be elucidated to you by Dr. Himika Chawla and Dr. Saptarshi Bhattacharya. Please listen to these trials, the conclusions and the carry home messages carefully, because they are very important for your day-to-day practice. So friends, my first request is to get Dr. Himika Chawla ma'am. She is a senior consultant endocrinology and diabetes, PSRI hospital. She is a DM endo from Cmes. She happens to, I have a connection with her. She is from MMC, and there are a lot of MMC guys here, including Lalit and Ranjan. She is member Endocrine Society of India. She has multiple publications in reputed high impact national and international journals. She has been a multiple awardee, and I request Dr. Himika Chawla to give her first presentation for today evening, ma'am. Welcome to the forum. Welcome to the forum, ma'am. All yours. My personal agenda, friends. Welcome to CME number 960. 40 short of 1000.
So good evening everyone. As the context has already been set, so of course Sir has emphasized how obesity, recognizing obesity as a chronic disease and managing it like any other chronic disorder, and the impact that it makes on the entire metabolic spectrum is what actually that's the good part with these weight loss drugs. So they've brought obesity into the picture as an important very very important risk factor to be addressed before we manage our patients with diabetes and reduce their various complications. And what's the role sort of semaglutide, particularly 2.4 milligrams injectable, which is Wegovy, in this? This is a financially supported talk by Novo Nordisk. So see, obesity is, of course, there is lifestyle component to it. There is lack of exercise, a sedentary lifestyle, the increased intake of processed food. So our diet and the exercise patterns have definitely changed over the last say 2-3 decades especially, but there's much more to obesity than just lifestyle modification, than just your wrong lifestyle. So actually in physiology, the energy expenditure and energy intake in the body is a very tightly regulated process. So the body tends to maintain it on a daily basis in a very balanced manner. It's only over a very long period of time that we have a significant increase in the energy intake or a significant reduction in the energy expenditure. Does it translate into weight gain over a longer period of time? Genetic factors are extremely important. Obesity runs in families, we know that. So there is there's a significant amount of genetic predisposition that obesity has, approximately 40 to 70%, and of course these environmental factors are actually inducing both the epigenetic changes which are leading to the change, which are driving this change in the expression of these genes. Beyond this, of course, we need to understand there are important psychological factors in today's times where there is chronic stress, a lot of people struggling with depression, anxiety, there is binge eating, food is a comfort thing for a lot of people, so that adds up to our calories. Then there is prolonged intake with medications like steroids, particularly during the COVID era, we saw a lot of people receiving glucocorticoids, even well beyond the COVID thing got over to deal with the long-term complications. So the chronic intake of weight-gaining medications like glucocorticoids and the various antipsychotic is an important factor that needs to be kept in mind. But what's most important is that obesity is not just about lifestyle. We need to understand there's much more to it, and it's a chronic disease and it has to be dealt like any chronic disease. So it cannot be dealt in a few months time or even a few years. It's a long-term process. You need to change functioning as a human being to be able to address obesity in the long term. And obesity is basically the chronic adiposity, which is sort of reaching to the point that it's impairing health and driving the increased risk of multiple cardiometabolic complications. So the appetite or the energy intake, as I mentioned, is a very tightly regulated process and it's controlled at various levels in the brain. So there are three ways where our appetite is controlled. First of all, by the hypothalamus, we have the homeostatic eating. So we eat for hunger, and this again is a balance between the orexogenic pathway and the anorexogenic pathway. So we have different peripheral signals. There are signals coming from the periphery like leptin, there is insulin, there is amylin, there is neuropeptide virus. So these signals are driving or they're stimulating the anorexogenic pathway, so inducing a state of satiety. Then there is ghrelin, which is our main hunger promoting hormone, which is released from the stomach, and that sort of increases the hunger. So usually there is a balance of these, and then they activate the the appetite stimulating or the appetite suppressing pathways in the hypothalamus. Second is the eating for pleasure. So that is called as the hedonic eating, which is basically controlled by the hindbrain. And of course there are certain foods that give us pleasure, and then we tend to eat them more. So this is this dopamine surge that it gives and the pleasure that it gives drives people to eat them more frequently and in a larger amount, leading to an excess of caloric intake. And then finally we have our cognitive functions. We have the frontal cortex, which is regulating what we are eating. So we can have a voluntary control on how much we eat. So if of course we are gaining weight, we would tend to exert a control on eating less, or if we are underweight, we would try to eat more. So that's where the frontal cortex comes into the picture, something that we can regulate on our own, something which is amenable to behavioral therapies also. But the pharmacotherapy, which has now come up in a big way, they're basically addressing both the homeostatic eating as well as the hedonic eating. So these drugs are they're sending peripheral signals. GLP is also one of the very important peripheral signal which stimulates the anorexogenic pathway, the PMC CART pathway in the hypothalamus to induce a state of satiety. So in addition to that, they also cause a suppression of the dopaminergic surge that certain foods give us. So these drugs are going to reduce both the hunger on a basal level and also reduce the cravings that we may have for certain foods. So of course weight loss is difficult, we know that, but maintaining weight is even more difficult, and this is because we have a lot of biological maladaptations which occur anytime we lose weight, whether it is through drugs, whether it is on our own through lifestyle modification. Whenever we try to lose weight, the body tends to cause an increase in the hunger hormones. There is a reduction in the satiety hormones, and there is also a reduction in the body's overall metabolism. So as I mentioned, it's positive energy balance over a long period of time which is driving that higher weight. But once your weight has been to a higher level, the hypothalamus is almost set to that level. So your original weight was say 60 kgs, you became 80 kgs over a period of 5 years. Now your hypothalamus is set to 80 kgs. Whenever you try to lose weight, the body's maladaptive response is to bring that weight back. So there will be all these changes that happen, and the body will do its best to bring its weight back to the 80 kgs no matter how much you try. These maladaptive mechanisms are most prevalent in the first couple of years after weight loss, after which if you maintain that lower weight for a longer period of time, will you be able to sustain that lower weight. So it takes at least the first couple of years to maintain a lower weight so that the body gets reset, or the hypothalamus gets reset to the lower weight. So metabolic changes to cause the weight regain are the thing that we have been struggling with whenever we tried to lose weight through lifestyle modification. And in fact, data shows that about 80% of people who lost weight are generally going to regain a large part of their weight within 5 years of that. So this is where pharmacotherapy comes into the picture. Till recently, till the time that we didn't have semaglutide or tirzepatide, we didn't have very good agents which could give us a good weight loss, plus have a very, either they were not giving us a very good weight loss or they were not having a very good safety profile. So now we have a drug which not only gives us weight loss, but it actually benefits or gives us a diverse range of pleiotropic benefits which are extending to most of our organs. So as I mentioned, GLP-1 is a key peripheral signal which works in the different areas of brain to control not only the basal hunger but also the cravings. So there is a reduction in the absolute amount of food that you can intake. So on an average, a person is expected to eat at least 33% lower than what he's eating on a baseline when he's put on a drug like semaglutide. Semaglutide is very similar to the indigenous human GLP-1. It has a 94% homology. Very importantly, it has a very long half-life, about a week, which allows us to give it only once in a week. There is both a direct activation of the hypothalamus promoting satiety, and there is also effect on the hindbrain, which reduces our cravings for certain foods. So it affects both the homeostatic regulation as well as the hedonic regulation. So your hunger goes down, your preference or cravings for savory foods, for sugary foods, for fried foods also goes down. So as Sir was also mentioning, Wegovy has a large program. So what this group of trials and this slide basically depicts is that it has an extensive patient drug development program, and it's been extensively studied, be it for weight management, be it in people with diabetes, be it in people without diabetes. It's been studied along with intensive lifestyle modification. It's also been studied, what happens when we withdraw Wegovy. So if we give somebody Wegovy for the initial 20-24 weeks, there's a good amount of weight loss. What happens if we withdraw it? Does the weight come back? And if we give it on a long term, does the drug become resistant? So do people stop losing weight after a point in time, and then do they really start regaining this weight back on a longer period of time? How long is the weight loss sustained once we start this drug? So all of this has been studied. Then there are selective trials which are focused on the East Asian, the Chinese, the Korean population. So you have a depiction of the East Asian ethnic groups also, which we want. Then there are, they've done trials in people with osteoarthritis, in people with pre-diabetes, and also very important, the STEP, HFpEF, diabetes and without diabetes trials. Now these are very important trials because they have been done to assess not only the cardiovascular safety but the cardiovascular efficacy of these drugs. So till now there has been no drug in the history for obesity which has actually produced cardiovascular benefit except for lorcaserin, which was of course not taken off because it had risks of malignancy. So this is the first drug which has produced a sort of 20% MACE reduction, and this has been seen in people with obesity without diabetes. So it reduces the ASCVD events, CV events in patients with established ASCVD, and that's been proven in the SELECT trial. It also benefits people with HFpEF, both in diabetes and without diabetes, which is what was seen in the STEP HFpEF trials. Then very recently we do have interim results from the ESSENCE trial, which is a trial which has been conducted in patients with MASH, the metabolic syndrome associated fatty liver disease. So here as well it has shown very good results in the way that it's reduced the steatohepatitis and it's also reduced the fibrosis, and the percentage goes up to 63% reduction in the steatohepatitis, almost a 36% reduction in fibrosis. Now what stands out in the ESSENCE trial is that here the MASH was biopsy proven, and the biopsy was done both at the start of the study and also in the end to demonstrate the result. So the regression of fibrosis and the regression of steatohepatitis has been done, has been studied on biopsy, which makes it quite worthwhile. Also, in addition to this, there is step-up trial which has explored the role of higher doses of Wegovy, going up to 7.2 milligrams in people with and without diabetes. So over 33 million patient years of exposure to semaglutide. So we have a large patient database. We also have an extensive drug development program. Now there's a significant Indian representation also. So semaglutide 2.4 milligrams, as we know, is Wegovy. So there is representation in the STEP trials as well. Then semaglutide 1 milligrams in the SUSTAIN program basically is with the semaglutide 1 milligram, which was initially basically used as the anti-diabetic drug, and then once it was used and the weight loss benefits were evident, then the higher doses like 2 milligrams and now 2.4 milligrams with Wegovy has been used to assess the entire chronic weight management effects that it has. Then Pioneer program, as we all know, is for oral semaglutide, that's Rebellious. So we have a significant representation from the Indian population also. Now first of all, talking about step 1. Now step 1 trial was basically conducted in people with overweight and obesity. So here the inclusion criteria was either the patient has a BMI of more than 30 kgs per meter square or more than 27 kgs per meter square with one comorbidity. It could be diabetes, hypertension, it could be obstructive sleep apnea, or it could be a cardiovascular disease. So if you have a BMI of more than 27 and any of these comorbidities, you could be given semaglutide. This drug is up titrated every 4 weeks, as we know. So it was started with 0.25 milligrams and then up titrated to 0.5, 1 milligrams, 1.7 and finally 2.4 milligrams. The titration phase was about 16 weeks, and beyond this, the study arm Wegovy 2.4 milligrams was continued through the rest of the study period, that's up to 68 weeks, and beyond that, from 68 to 75 weeks, the treatment was taken off because it's a long-acting drug, so the off-treatment follow-up was done, and then the endpoints that were taken as a part of this trial were the percentage of weight loss and people who lost more than 5% weight. Confirmatory secondary endpoints were people who could lose even more weight, and benefits going beyond weight loss, reductions in waist circumference, the systolic blood pressure, the quality of life, so that was also assessed. Now these are the results. So here we have a mean baseline weight of 105 kgs. So at the end of 68 weeks, as we can see, the weight loss that was seen with Wegovy was 16.9%. So there's a 16.9% reduction at the end of 68 weeks. As we can see in this graph, the maximum amount of weight loss happens in the first 24 to 28 weeks. Beyond that, the weight loss slows down and it sort of reaches another around the 1 year mark, and then it continues, it plateaus, but patient continues to maintain that same weight while he's on the drug. When you talk about clinically meaningful weight loss, we know that as doctors we know any weight loss is helpful, and a minimum of 5% weight loss is what we consider as meaningful weight loss, because it will produce significant improvements in your blood pressure, your lipids, your diabetes, the osteoarthritis, your fatty liver. So a minimum of 5% weight loss can actually produce meaningful metabolic improvements. So as we see, 92.4% of people, so most of the patients who were on Wegovy 2.4 milligrams lost more than 5% of their weight. Almost 3/4 of the patients, that's about 75% of the patients, lost more than 10% of their weight. This was around 55% weight. 55% of the patients could achieve a weight loss of more than 15%, and even about 1/3 of the patients, that's about 35% of the patients, could actually achieve a weight loss of more than 20%. Now this is something which nears a bariatric surgery kind of an outcome. So one could not think of pharmacotherapy reaching to a 20% weight loss. So almost 1 in 3 patients is actually reaching that kind of a number. Of course, all of these patients were offered reduced caloric diet. So there was a calorie deficit of 500 kilocalories that was induced on a daily basis, and they were asked to exercise regularly. So the lifestyle modification was also in place along with the drug. So we are talking about weight loss being the center of the entire metabolic improvement thing, and does it actually translate into effect? That was also seen as a part of this trial, the various CV risk factors. So the waist circumference, a very important marker of visceral adiposity, reduced by 15.2 centimeters as compared to 4 centimeters in the placebo group. There was significant improvement in the blood pressure, 7 millimeters of mercury reduction in the systolic and 3 millimeters of mercury reduction in the diastolic blood pressure. The A1C also reduced by 0.5%, but yes, these are non-diabetic people. So their baseline HbA1c was less than 6.5 to start with. Still they had a 0.5% reduction in the HbA1c. The function score, the SF66, SF36 functions, physical function score also improved significantly. So in addition to that, a marker of a systemic inflammation that we use, CRP, also reduced by 58%. So the weight loss had actually translated into a better cardiometabolic profile also. Now coming to step 4. Now step 4 is a trial which has looked at what happens when we withdraw Wegovy. So in this trial, in the run-in period, all the people were put on Wegovy and they went up to 2.4 milligrams weekly dose. Beyond the 20th week, they were randomized into one of these arms. In one arm, they were continued on this 2.4 milligrams of Wegovy. In the other arm, they were shifted to a placebo, and this was continued till 68 weeks. 68 to 75 weeks was the off-treatment follow-up period. Again, the inclusion criteria was similar. People having a BMI of more than 30 kgs per meter square or more than 27 with a comorbidity. Again, this was a non-diabetic population. HbA1c less than 6.5. So it included people with pre-diabetes. Here again, the change in the body weight from week 20, that's when they were shifted to one of the two arms, Semaglutide versus placebo, till the end of the study period was the primary endpoint. And then of course the improvements in the other metabolic parameters like waist circumference and blood pressure was also seen. So as we can see, till week 20, people lost an average of about 11% of their body weight. Now beyond this, beyond the 20-week mark, people who continue to be in, receiving Wegovy, they lost an overall weight of 18.2% at the end of 68 weeks. Again, this plateauing after a year, that's about 52 weeks. And people who were discontinued on Wegovy and shifted to a placebo, they regained a significant portion of their weight back. So they were at a weight loss of 6.9% from their baseline at the end of 68 weeks, which means they regained close to 3 to 4% of their weight was regained at the end of the study period. So people who discontinued Wegovy had a regain in weight, which just reinforces what we said. Weight loss by any means is going to drive a regain of the weight. So it's important to manage obesity in a chronic manner. Obesity cannot be addressed in some months. It's a chronic disease. It needs to be managed on a long term, over a longer period of time to get sustainable results. So now coming to step 5. Step 5 is a trial which is looked at giving maintenance Wegovy over a longer period of time. That's more than 2 years. So here people were kept in two arms. Again, one is the Wegovy arm, other is the placebo arm, and the treatment was continued for good 2 years, and the end of treatment was week 104. Beyond this, the end of the trial was 111 weeks, and again the endpoints here was a change in the weight, people who could lose at least 5% of their weight, and the inclusion criteria was similar. Again, a non-diabetic population, A1C less than 6.5. So as we can see, the weight reduction here again similar, about 16.7% from a mean baseline weight of 106 kgs. Now the point they want to make out here is, if you continue Wegovy, the weight does not come back. So you don't develop resistance to the drug. The weight, though there is a plateau which will be achieved, so once you reach the maximum efficacy of this drug, so this drug is capable of giving you a maximum weight loss of 20%. Once you reach that and you plateau, you may not lose further weight, but should you continue the drug, you will not regain also. So chronic management when done with this drug will give you sustained results over a long period of time. You'll be able to retain that weight loss. And the SELECT trial, as we know, is a trial where in obese people with diabetes, the cardiovascular efficacy of this drug was assessed. So, of course, this was a longer trial, and people were continued on Wegovy for a period of 4 years. So, this trial also, the weight loss was sustained over a period of 4 years. For people who continued on Wegovy, they maintained their lower weight for the duration of 4 years. In all of these trials, in all these step trials, in all of these trials, 1 in 3 people, or almost 1/3 of the people, it's only when you combine it with the sulfonylurea or insulin. So it's suitable for adult patients with a BMI of more than 27 with comorbidities, or 30 kgs per meter square without any, regardless of any comorbidities. Weight loss can go up to 20% in 1/3 of the patients. The average weight loss is about 15 to 18%. The weight loss is sustained. Trials have been done which are exceeding, almost going up to 4 years. The weight is maintained over a long period of time. So it's suitable for chronic weight management. There are significant health gains. So it not only causes weight loss, it translates into a much better cardiometabolic profile. It gives you multitude of benefits going beyond weight loss, which is reduction in the CV events, which is demonstrable with the SELECT trial, which is a significant improvement in steatohepatitis and fibrosis seen with the ESSENCE trial, significant retardation of progression of renal disease seen with the FLOW trial. So, of course, we can consider it a class effect, and we can say all of these are coming with the weight loss, but till now it has been demonstrated only with semaglutide. So we can say as of now that semaglutide causes weight loss, and it also gives you these additional benefit when it comes to cardiac, renal and hepatic comorbidities, which are very commonly seen in patients with obesity and diabetes, obesity with or without diabetes. Thank you for the patient hearing.
Thank you, Dr. Himika. We will have question and answers in the end. I think she gave a wonderful deliberation on the role of injectable semaglutide on patients with obesity in step 1, and patients of obesity with diabetes. And she also brought home the important point that the meaningful weight reduction is at least 5% of the baseline, although there have been trials, and she showed that 1 in 3 patients, they achieved a significant weight reduction of as high as 20%. Although I think across all the step trials, the average weight reduction was about 14 to 15%, and we'll talk about it more when we start discussing. The next talk is going to be by Dr. Saptarshi Bhattacharya, our Superman endocrinologist from Apollo Hospital, the gentleman who always helps us in our times of need. Sir, over to your deliberation. He promised me that he has a very short deliberation of only 15 to 20 minutes, but he will discuss points which you can keep on discussing for next 15 to 20 hours. But for next 15 to 20 hours, we'll have to have at least another 15 CMEs from Mr. Sunil Yadav and Mr. Anuj. I'm sure that they will have to hold fort beyond the patent expires in March 2026. So we are assured of a lot of CMEs from them. Sir, over to you. And Dr. Saptarshi Bhattacharya is a senior consultant, endocrinology, Indraprastha Apollo Hospital. He is a member, Education Working Group, International Society of Endocrinology, ex-secretary, South Asian Federation of Endocrine Societies, Executive Committee member, Endocrine Society of India, Executive Committee member, Indian Thyroid Society, Honorary Secretary, Endocrine Society of Delhi, ex-President, Society for Promotion of Education in Endocrinology and Diabetes. SPEED, they have a wonderful conference called SpeedCon every year, and he has always been very kind to me to make me a chairperson in many of those meetings. And sir, thank you very much. I used your Amazon cards on Diwali, sir. 115 publications in index journals. Big hand for Dr. Saptarshi Bhattacharya. He'll bring us up to date to some more information on Wegovy. Sir, over to you.
Thank you, Dr. Chauhan. So I think it's going to be my fourth or fifth presentation in this forum, and it's always a pleasure to deliver the talk, and it's even a bigger pleasure to answer the questions which I will face after the talk, including some very intricate physiology questions which today I have decided I will refer it to review articles whenever you ask about mechanisms. But if you have asked any clinical question, I will try to answer that. So we will be talking about semaglutide. Already Dr. Himika has discussed most of it. My job is already done. So it's a challenge. So it's very easy to tell when you come in a conference and or a CME and discuss, okay, this is obesity, so and you need to treat it as a chronic disease, but when a person is sitting in front of you in the clinic and you try to, maybe there will be people, or obviously things have changed, so there has been more awareness of obesity, which is a good sign. So there are actually people with obesity who are coming and telling that I have heard about these medicines and I want to take one of these medicines. So this is something which we hardly have seen before, but because one of the reasons is that these are medications which are actually effective. So before this, the best thing we had was something like a liraglutide or orlistat, which caused around 5 or 8% weight loss at most. So and we didn't have that much of answers to deal with obesity, apart from maybe offering a bariatric or metabolic surgery. But now things have changed, so we have medications which can bring down weight by 15, 20, 22 or 25%. And just to give you a perspective, so if somebody is coming with a weight of 100 kg and has tried everything and will come to your OPD and tell, okay, I joined this gym, I joined this diet program, and my weight was 100 kg. I came down to 93, but I stopped it and I gained back, and now I am at 102. So these are usual situations which we had in our clinical practice, but now hopefully things have changed. But even today also we have challenges about making people accept that somebody needs to take a medication for obesity. So that is something which has remained a challenge, and we need to, so how we can make them understand is to make ourselves aware about the information, about the knowledge, about the trials, about the evidence which you have about these molecules, and once you are convinced, so you will also be able to convince the people who is sitting in front of you and who is telling, nahi, Doctor Sahab, iska side effect kya hoga? So they are not concerned about the side effects of obesity, they are not concerned about the side effect of diabetes, but they are concerned about the side effect of a molecule which is supposed to protect, which is proven to, not supposed, proven to protect the heart, proven to protect kidney, proven to protect liver, proven to decrease weight, proven to decrease blood glucose level, and so there are multiple proven benefits, and obviously at the heart of all these things, the cardiovascular disease or cardiovascular mortality remains the main challenge, because ultimately, be it diabetes, be it obesity, so most of the mortality and morbidity will be because of cardiovascular disease only. So there are other complications, but they are the primary drivers of morbidity and mortality in people with metabolic diseases, including diabetes and obesity. So there is a huge burden of cardiovascular disease, and in India, apparently we think that we are not very obese, but we have a lot of visceral adiposity. So, and that is something which actually drives the CV mortality and the complications and the risk for diabetes, risk for MASLD, progressing to MASH and then progressing to cirrhosis. So even though we don't look very obese, but the visceral adiposity or the abdominal adiposity is something which is a primary driver of many of the complications of obesity. And when we started, so when we discuss about, still at least we have that luxury that it's understood if somebody is having diabetes or having hypertension, so that person will benefit from medications. So people know that. So people might not be following it, might be following it. Some people might feel, okay, I'm having a A1C of 9.5, but I don't have any problem, so I don't need to take any treatment. So there will still be a subsection of people who have that mentality, and the sad fact is that in spite of the best of medications we have, so still 60-70% of from the best of centers of all across the world will still have a H1C which will be more than 7%. So, but at least somebody who has diabetes or hypertension, even if they're not following, not getting treated, they know that, okay, I maybe I am doing something wrong. But on the other hand, for obesity, we have that stigma that if, okay, I have obesity, but I am getting treated, maybe I am doing something wrong, I am not doing the right thing. So maybe the naturally losing weight is the best way forward, and taking a medication might be something which the celebrities might be doing to lose weight, and but not something which should be done for a common person. And what will be the side effect of this molecule? So that is not true, because it's obesity and overweight actually increase the risk of CV events by almost 3 times. So the chance of cardiovascular disease, the chance of cerebrovascular disease, the chance of heart failure, so all of them actually increase along with weight. So we have to keep on reinforcing that obesity and overweight conditions are a primary driver of many of these morbidities and mortalities. Just to give you a perspective, so there was one concept which was doing the rounds, that there is a obesity paradox, that okay, obesity, some amount of obesity is protective, so some amount of so there are people who have obesity and the mortality might be lower in them. But again, because the concept is that everybody has a fat tissue or adipose tissue threshold. So, and once somebody reaches that particular threshold, so then from the subcutaneous tissue, the fat tissue actually starts spilling over to the viscera. So it will go on to the liver, which will cause fatty liver, and which has been renamed as MSLD and can progress to MASH. When it progresses, when it gets deposited in the pancreas, so there is the twin cycle hypothesis which has shown that fat in the pancreas, adipose tissue in the pancreas, can be a driver of the pathophysiology of type 2 diabetes. And even there are studies which suggest that epicardial fat adipose tissue can be a driver of or a marker of cardiac disease. So apparently, even metabolically healthy obese people who do not have maybe an inflamed biomarker, so chronic inflammation is doing the rounds in social media a lot nowadays, that Instagram is full of information and influencers who suggest that everything is being driven by inflammation. So you have a particular food, so that is causing inflammation. You have this natural food that won't cause inflammation. So, and that is, if you can take care of inflammation, and that will help you avoid all the complications. So again, that does not have much of scientific validity, but what we know is that whenever the adipose tissue increases above a certain threshold, so that becomes dysfunctional, that secretes more inflammatory mediators, that secrete more cytokines. So there is this concept of metabolically healthy obese people who are apparently they don't have those inflammatory markers, and they might feel they're doing quite well. But even in them also, if you look into the rates of stroke or rates of cardiovascular disease, that they are actually quite higher than the normal population. And if you look into the metabolically unhealthy obese, the risk of cardiovascular disease is almost 2 times. So we need to again reinforce that cardiovascular disease is a complication of obesity. So if we are not thinking about treating diabetes, if we are not thinking about treating hypertension, sometimes we do have still challenges about treating dyslipidemia, because the person will tell, okay, my LDL has come down, my cholesterol is actually low, why should I be taking a statin? So that is again not true. So similarly, if somebody comes and feels that, okay, I am having a BMI of 34, but I don't need to get myself treated, why should I get treated? I am quite okay, I can do everything, I don't have any problem. So maybe it's time that we have a relook at the situation. So what we know till now is that weight loss improves traditional cardiovascular risk factors. So it will, if a person loses weight, the blood pressure will go down, the lipid parameters will improve, the glycemic control will get better. Those who are having diabetes, their glycemic control will get better. Those who are having pre-diabetes, the risk of progression to diabetes will be less, and there will be a higher chance that they become normoglycemic. And at the same time, so we have evidence from bariatric surgery where the usual weight loss is in the range of 20 to 30%, that has a beneficial effect in terms of CV risk reduction. So what Dr. Himika was telling was that there are very few molecules for anti-obesity molecules which actually have been shown to cause a CV benefit. So there are multiple trials which were there. There were molecules like sibutramine or rimonabant, so they actually got withdrawn from the market. So there even lorcaserin got withdrawn from the market. Naltrexone bupropion combination is still available in US. We don't have it here, but again did not do well in a CV outcome trial. So as of now, if somebody is asking why do I need to get myself treated for obesity, we don't have an answer unless we had this trial where it's showing that if somebody who has obesity or who is overweight and had a prior cardiovascular disease, then if you are giving this injection, that actually decreases the chance of MACE. So you can prevent major adverse cardiovascular outcome if you are injecting this molecule. So this was a trial which was done. We have heard about the CV benefits of injectable semaglutide. So we have trials for that. But again, so what we'll be talking today is about the obesity perspective, where only people without diabetes and having obesity were studied across 41 countries, 800 sites, and almost 17,000 participants. So a large multicentric trial, 492 participants from India. So this was again the trial design. The primary endpoint was a composite of CV death, non-fatal MI3 or non-fatal stroke. There were some secondary endpoints also. This was the trial design. So person was receiving semaglutide 2.4 mg injectable, and the other arm was receiving placebo. All these patients had a BMI which was more than 27, age was more than 45 years, and all of them had a prior CV event. It could have been a stroke, it could have been a CAD, myocardial revascularization, or a symptomatic peripheral vascular disease, and all of their HbA1c was actually less than 6.5%. So this was a trial which was done for people without diabetes, only obesity or overweight, and with prior cardiovascular disease. So these are the baseline characteristics of the participants. So MI was there in 67%, stroke in 17.8%, peripheral vascular disease in 4.4%, around more than 2 CV inclusion criteria in 8%. The breakup of the ethnicity, and this was the mean age was around 61 years. So the mean HbA1c was 5.8. So the people were hovering around the pre-diabetes range. Mean BMI was 33. GFR was mostly normal. Chronic heart failure was 24.3%. They did a separate subclass analysis for this, and this was the distribution of BMI. pre-diabetes was present in 66%. And so you must have seen in clinical practice, so if somebody is starting with a HbA1c of 10 or 11%, or even if you are thinking about weight loss, somebody is starting with a higher weight, so the reduction in HbA1c, the reduction in weight is going to be more. If somebody is maybe 75-80 kg, trying to lose weight, or maybe HbA1c of 7.5 or 7.8, trying to get the HbA1c down, the results are less effective. So the molecule, if you try to study a molecule, it's less effective. So here we have a situation, so most of these people are getting the best standard of care like medications for lipids, blood pressure, antiplatelet therapy, and if they developed interim diabetes, they are getting the standard glycemic management, healthy lifestyle guidance. So whatever is the standard of care, so all is being given. So to prove or having cardiac superiority on top of the standard of care, that actually becomes a challenge. So you can see that as per guidelines, almost majority of these patients are on platelet aggregators, lipid lowering agents, beta blockers, ACE inhibitors or ARBs, calcium channel blockers, and majority of these molecules have a beneficial effect on CV risk reduction. So the standard of care has been provided in both the arms, and what we see is that the people started having a difference in the major adverse cardiovascular events. So there are over a period of like 48 months. So there is a 20% risk reduction in MACE in patients who receive semaglutide. So again, to remind you, so these are people who are only having obesity, who will definitely, if you try to offer them this molecule, they will definitely challenge your treatment that I don't have a problem, why do I need to take a costly injection once a month. But this is something which is going to actually prevent a future risk of cardiovascular events. So this is not non-inferiority, so it's proven CV superiority. If so, you don't think about giving a statin or an aspirin to a person who had a prior heart attack. So if we go by this data, so this is a molecule which also is having similar benefits, at least towards that, some amount of benefit reaching towards that stage where the future risk of CV event is going to go down. So that is actually recommended by the European committee, that GLP-1 should be used in people with overweight or obesity, even without diabetes, to reduce the risk of CV mortality. So that is a standard of care. So with the cost coming down, this might actually also be helpful. So if you look in the Indian recommendation, so it's indicated to reduce, we go with 2.4 mg, indicated to reduce the risk of major adverse cardiovascular events. So we had almost data from close to 400-500 people from India as well, where just obesity and prior cardiovascular disease, the risk of CV event is going to go down, and this is proven in a trial which included almost 17,000 people and across all continents, including almost 400 people from India. So if you look into the risk reduction, that becomes soon after so the line starts separating early. So why it happens, if you are going to ask me after this, we don't, still it's a subject of research, I can't give you an answer for that, so I raise my hand even before you ask that question. So but again, so this, you can see this line starts separating early. So there are multiple factors including a reduction in inflammation, because what we see is that the hsCRP levels actually go down significantly whenever the person is getting this molecule. So even before the maximum weight loss started, which occurred around say 14 months of therapy, but the CV benefits were actually observed much before that. So some of the benefits are actually independent of the weight loss. So even if the person is not losing weight, there is maybe 5-10% will be non-responders, which is very, very unlike the previous molecules where majority used to be non-responders. So in spite of that, the person will have a CV benefit. And if you look into the type of CV benefits, so it's beneficial across all measured CV outcomes. So sometimes we know that the SGLT2 inhibitor data is primarily driven by heart failure data. So, but again, so if you look into the different types of CV events, so all of them actually go down, and 18% risk reduction in the composite heart failure outcome also has been seen. 15% reduction in CV death was seen, which the p-value was 0.078, just barely missed significance, but there was a significant trend towards reduction. So this is a bar diagram of favoring the individual outcome. So if you look into MACE, it was benefited. So if you look into CV death, so there was a 15% reduction, but did not, just barely reach statistical significance, the line crossing just barely. Composite heart failure outcome statistically significant, all cause death statistically significant, expanded MACE statistically significant, non-fatal MI, non-fatal, so, and combination of non-fatal and fatal MI that came down. The stroke data did not do that well. Hospitalization for unstable angina again didn't do that well, but nephropathy also actually, we know that obesity can be a major driver of nephropathy, that also came down. So if you look into the factors which are usually responsible for weight, the benefits of cardiovascular benefits, so CRP is one of the marker that came down by 39%. Weight loss, the average weight loss in the semaglutide group was 11.7%. We were discussing about visceral adiposity, abdominal obesity, so that came down by 7.7 centimeter. So HDL went up, LDL came down, HbA1c even in the pre-diabetes group it came down, and there was almost 4 to 5 millimeter reduction in systolic blood pressure and 2 to 3 millimeter reduction in diastolic blood pressure. So the chance of pre-diabetes going into remission, normoglycemia, that significantly increased with Wegovy. So we know that most of the people with pre-diabetes, so they actually tend to go and progress into diabetes. So we can actually like reverse the cartwheel in this situation. So this is the first molecule which across a large group of patients, 17,000 patients, participants, showed CV superiority, and that is something we actually need to incorporate in our practice. And we have real world data also, which was a SCORE trial where so analysis of CV data from mostly from insurance with overweight, obesity and ASCVD without type 2 diabetes. So MACE, revised MACE, CV mortality and all-cause mortality, so they all were significantly decreased when the person was receiving this molecule after obesity and a CV event. So what we learn from this is that, so we might still be trying to convince our patient why you need to take an anti-obesity molecule, but as of now, if we look into, we don't have a primary prevention data, this is secondary prevention data, but at least if we are taking home one information is that if somebody is sitting in front of you, had a prior CVD, had a revascularization or maybe a MI recently, then that person is a very, very strong candidate for this molecule, because there is a proven safety and proven efficacy of this molecule in preventing a future cardiovascular event. So to summarize finally, so there are, we have done quite well. So maybe if 20 years back we had very few molecules which had CV superiority. So things have changed, science has progressed, so we have multiple things to offer. But obviously one constraint remains the cost, which has come down by 37%. So the Novo team has partially taken care of it. But the other constraint remains sometimes the GI side effects. So the dropout rate was around 16%, largely because of GI side effects in the trial. So maybe 7 or 8 out of 1 out of 7 or 8 patients will not be able to tolerate this medicine because of GI side effect. But if somebody can tolerate this molecule, can afford this molecule, there's a very, very strong cause to use it to prevent a future cardiovascular disease. Thank you once again for your patient listening. I now hand it over back to Dr. Chauhan.
Thank you, Dr. Himika Chawla, and thank you, Dr. Saptarshi. डॉक्टर कांतूर सर सवाल पूछ के जाइए, ऐसे मत जाइए, सवाल पूछ के जाइए प्लीज। डॉक्टर हिमिका मैम प्लीज। मैम बैठिए प्लीज, माइक दे दो, माइक दे दो। So we had a wonderful deliberation. I am sure you will have a lot of questions. So it's 10:20, entire thing by 10:40. The question answer session, and I'll set the context. Sir, Dr. Luthia sir, आपसे तो सवाल की उम्मीद है सर, आपसे सवाल की उम्मीद है सर। और सर उम्मीद पे दुनिया कायम है, उम्मीद पे दुनिया कायम है। डॉक्टर हिमिका मैम, wonderful deliberation. I just wanted to ask you, ma'am, we have heard a lot of trials on weight loss medications. Ma'am, with your educated observation on all these trials, and even Dr. Saptarshi can join on this, more the weight loss, more the benefits. Is that the message for everybody, ma'am? More the weight loss, more the benefits.
Sir, I would say any weight loss will give some benefit. So I would put it that way. But yes, of course, it's been seen, and there is ample amount of data which shows that what a 5% weight loss can give you, what a 10% weight loss can give you, and what a 15% weight loss can give you. Of course, as Dr. Saptarshi was mentioning, the relationship with CV disease is not that linear. But when you talk about weight loss and drugs like these, what it gives you is a pleiotropic benefit. So you not only reduce the cardiovascular events, you also reduce the risk of MASH, its progression, the fibrosis, the risk of hepatocellular carcinoma. Then you have a regression of renal disease, which is very prevalent in people with diabetes. Diabetes being the leading cause of nephropathy and CKD. So I would put it that way that if you have a 5% weight loss, as I mentioned, you could have better blood glucose control, you could have better management of your dyslipidemias, your hypertension, you could have also some benefit in your mechanical complications like osteoarthritis and sleep apnea. A 10% weight loss, you could have, you could start having some resolution of not only the steatohepatitis but some degree of fibrosis, which becomes again, which correlates with the weight loss. So if you have a higher degree of weight loss, there is data, and we see in our clinical practice that we have regression of the fibrosis scores also in people with and without diabetes. So yes, I would go by the statement that the higher the percentage of weight loss, you would get multiple benefits. But I would not completely can't vouch that higher the weight loss and the degree of CV benefit would translate linearly. Put it that way.
Ma'am, you in one of the STEP trials you mentioned that if you stop the medication and you replace it with placebo, there is actually a weight gain. So suppose we give the patient injectable semaglutide for about 68 weeks and we achieve a weight reduction of, let's say, about 15-17%. What should be our future strategy for this patient? An intensive lifestyle modification, or can we give this patient, instead of injectable semaglutide, oral semaglutide? Will that, although it has not been a part of the trial, of the constructed trial, but can that be a strategy?
Sir, one is what we know theoretically, what we are doing, and one is what we do practically. So of course these drugs are designed for chronic weight management. So they want these drugs to be given for a longer period of time. As I was mentioning, the weight regain phenomena and the maladaptive responses are most prevalent in the first 1 to 2 years. So yes, if you are able to reach and if you are able to maintain a certain degree of weight loss for, I would say, at least a period of 6 months plus, it can be a good time to start down titrating. But of course, the patient needs to be sensitized on the importance of strict lifestyle modification and the tendency for weight gain that can very well happen over the next 5 years also. So yes, you need to give it for a longer period of time. You cannot stop them abruptly. You need to continue the diet and exercise part, but we can down titrate. And of course, affordability is an issue with the cost of these drugs also. So I think this is something that we will utilize. We don't have experience more than 7-8 months with these drugs since they've been launched only in April. So we are just completing about 8 months with this drug. So we also have to wait what kind of strategies we can use. But we are doing this in our clinical practice, that once there is a plateau of weight loss, so that the people don't regain weight, so that the people maintain that certain sense of satiety, they don't start eating again, we can shift them to a lower dose of oral semaglutide, something that can fit in their bill, something that they can continue over a little longer period of time. But yes, I would strongly recommend that once we start these medications, we counsel our patients that we're going to give it for at least 6 months to 1 year. If we start them abruptly before that, there is definitely going to be weight regain.
Thank you, ma'am. Dr. Saptarshi, wonderful deliberation on
so
the
maybe if I can take that question slightly. So I think that is something which is $1 million question, and we don't have the trials addressing them. And since so even though you have been using Ribelsis for a long time, but both whatever weight loss medications you are having, so we are just in the phase of up titrating them. We have not reached the phase of down titrating them in our clinical practice. But if you discuss with people who have been using these molecules for a slightly longer duration, so first of all, if a person wants to continue it, so there is no harm in continuing it, there is only benefit in continuing it. So we have to move away from that thinking of obesity. So it's not that if you are, say, somebody's BMI target should be less than 23, so that is how Indians or Asians should be. So that is our ideal BMI target. So ideally, if you first of all, you won't reach a BMI of 23 in majority. So in that case, so since you have not reached your target, so if you are trying to control diabetes, and if somebody's HbA1c is 7.2, 7.3, or if you're trying to control blood pressure and somebody's blood pressure is 142/92, you won't think about stopping medication in that person. So we need to think about obesity in the same line. So we are discussing all this because it's an injectable and it's a costly molecule. So had it been costing like 10 rupees a month and we are getting 10 rupees a tablet and we are getting all these benefits, we wouldn't have discussed it. So it's a cost issue which has come in, and that is leading to all these questions about how to down titrate. So first of all, my take is that if somebody is comfortable continuing it, it's actually it's not that there is no harm in continuing it, it's actually beneficial to continue it. Because the benefits are going to be, we have trial data for 48 months, but I'm sure we'll have more trial data. So if the person continues, CV benefits and liver benefits, so that is only going to increase. So now what happens if somebody has reached a target BMI of less than 23? So actually the question of stopping the medication or discontinuing the medication or down titrating should only come in that situation. So it's like you have sort of gone into a diabetes remission. So in that case, so there are multiple options, but people don't have an answer, because even then, for them also, for US or Europe also, where they have been using it for a slightly longer duration, so there are not many trials which have tried to analyze that, okay, you stop at a particular BMI, then you continue with a lower dose, shift to a oral, continue with intensive lifestyle, which is the best strategy. Nobody has an answer. But I think as of now, if somebody is comfortable in continuing, so even if the HbA1c has come down to say 5.8 and somebody is happy to continue metformin, so we don't think that somebody is going to do a crime in that. So we will think it more of it as a norm. I think at some point of time we need to think about obesity in the same way. The mortality rate with a obesity, unhealthy obesity, is 2 times that of a normal person. So it's time we realize it and don't think about stopping this molecule.
So one of the criticisms of the weight loss medications, whether oral or injectable semaglutide, has been that as we continue to use the oral semaglutide, there is a ceiling effect when we go to 14 milligram. Right. Now I want to ask you one thing, sir. Suppose I had a patient who only needed to achieve about 6 to 8% of weight loss, and he achieved it with 14 milligram, and his HSCRP is significantly down, the other inflammatory markers are significantly down. Should I continue with oral, or now in light of whatever is being shown with the step trials, ma'am, should I change to injectable, or am I obliged to change to the injectable, or I can continue with oral semaglutide if I have achieved my target weight with that patient? Diabetes is under control. As you said, there are two arms of treating this. One is to achieve a glycemic parameter. Second is to achieve a significant weight loss, which you mentioned 5% of the baseline. And I achieved it with 14 milligram. Can I continue with that dose for life with this patient? He or she is comfortable taking the oral tablet, they don't want to go to injectable. Is that a good strategy?
That's a fair strategy, sir, and we have to, of course, diabetes is about individualization. We don't always go by guidelines. We individualize the kind of treatment that our patient can continue in a longer period of time. Of course, as you mentioned, diabetes control and weight management, these are chronic weight management, these are the two defined indications, and of course, Wegovy is the higher dose molecule. So basically you need higher weight loss for the weight loss. Oral semaglutide, there's a capping on the dose that we have available now. Of course we have 25 milligrams and 50 milligrams, which is gone through the trials. It's showing results which are comparable to the injectable also, but we don't have that available right now. So wherever we need, we have an unmet need for weight loss, of course we'll go. But in your case, as you mentioned, the patient has already been optimized. So, even if you talk about the cardiovascular data, you have efficacy shown both with the oral and the injectable. So you have the sole trial for the oral, and you also have this trial for this injectable, but the reduction is more. The MACE reduction is 20% with the injectable, it is 14% with the oral semaglutide. But I think practically it is a fair option to continue. It will be difficult for such a patient to be convinced to shift to injectable.
Thank you, ma'am. Sir, you showed a wonderful slide with the select trial where everything was to the left of the unity line. One thing that was missing, and I would have wished it could have been a part of the trial, I don't know whether it was or not, the OSA, obstructive sleep apnea, it was not there on the chart. Your take on that? So I would think that if you decrease weight significantly, OSA would decrease significantly.
So again, that has been studied with tirzepatide, not with semaglutide. So we don't have large data related to that. So they were looking into the CV outcomes only. So it was a dedicated cardiovascular outcome trial. So that aspect was not taken care of. So, but it's a corollary that if somebody is losing weight, the OSA should also benefit, and it's presumed that it should benefit because it's known that if the weight goes down, it should benefit.
Dr. Saptarshi sir, Dr. Mathur sir, our mentor and our patron, he has a question.
Good evening. Very nice talking to both of you. It's very enlightening about obesity. Obesity is a disease, as like thyroid, diabetes, hypertension, all. And it is a metabolic condition, as we call it, and it is genetically predisposed. We don't know the cause of obesity. Every individual can have IM, BMI, business lifestyle. So treatment of obesity is, as rightly said by you all, is lifestyle management, which is very difficult to achieve the target weight. So weight loss medicines can be given, but how long to be given? If the patient accepts that GLP-1 agonists have got a lot of side effects, like GI side effects. Sometimes you said 15%. I had about 6 patients, 3 of them dropped out. Severe diarrhea, vomiting, not tolerated. So this can be possible that we have to modulate the treatment. But my point to contain that the obesity has to be treated for the rest of his life. It can come back after treatment also. So what is the take after achieving some say 18% weight loss included? Should we continue low doses of GLP-1 agonist, oral or injectable, whichever? What would you advise on that?
So again, obesity is a chronic disease. So we don't think about treating chronic disease, and I maintain the same stand that the treatment should continue. Whether if somebody has got, again, 5% weight loss is the criteria where an obesity medication should be, that is required for approval, but again that is not the target. So that is the minimum weight loss that one should achieve. So ideally the target should be to get to BMI of less than 23. So once somebody reaches it, whether you need to continue or not, so that is a grey area. So I again maintain that. So again, if the continuation is not a problem, so the GI side effects will be primarily at initiation or during dose escalation. So if somebody is tolerating say 1.7 or 2.4 mg and have been able to reach that dose and have been able to continue it for 6 months or 1 year or so, and had a weight loss of say around 15% or 18%. So if you are planning to continue, what we can ensure is that the weight is not going to come back. So obviously at some point of time the weight is going to plateau, but again the continuation should not be a problem in terms of GI side effects. So, and mostly the CV benefits and the hepatic benefits and the renal benefits are only going to be advantageous to the person who is taking it. So and overall it's going to be the health is going to get better. So but what happens after 5 years, 10 years? So if you ask for RCTs and scientific evidence, since these molecules are here semaglutide injectable got launched in 2017, the obesity one got approval slightly later. So we have not used these molecules for such a long duration so that we can comment on what happens later. But whatever data we have, whatever information we have from real world usage, even in US or Europe, so it's to everybody's benefit. Apart from the cost, if the person is able to afford it, we should be continuing it.
Thank you, sir. But achieving target of 23 BMI is asking for more. Thank you.
But again, that is a target. So
very difficult to achieve by anybody.
Doctor, absolutely agreed. But that will give the best metabolic health benefit which you can get. So that is a target. So if you are
non-achievable targets.
So बच्चा जो स्कूल में फर्स्ट होने का कोशिश कर रहे हो, अगर 5th भी हो जाए तो parents will be happy. So even if you start at 32 and if you are reaching BMI of 25 or 26 with a target of 23, so that is still something.
Dr. Sankalp Pandey has a question.
Good afternoon, sir. It's a very enlightening talk. Sir, एक क्वेश्चन है मेरा कि patients suffering from the arthritis and low back ache always ask कि weight reduction के लिए कुछ करना चाहिए या कुछ मुझे tablet लूँ या मैं कोई ऐसी exercise करूँ, and more so after the surgery, क्योंकि उनका main concern यही रहता है कि जिसका TKR किया है, जिसकी low back ache की surgery की इसमें particular screw डाले हैं, वो पेशेंट हमेशा यही पूछेगा कि मुझे जो है वेट रिडक्शन के लिए सबने कहा था फ्रॉम लास्ट 15 इयर्स, मैंने वेट रिडक्शन नहीं किया और उसके बाद मेरी हालत यहीं पहुंची है और मुझे सर्जरी हुई है. इसके बाद करने के लिए कैन यू ऑफर समथिंग व्हिच वी कैन ऑफर द पेशेंट्स?
Dr. Sankalp, can I just relate a patient? I had a patient who is a diabetic and a borderline diabetic but had a BMI of 31 kg per square meter. I put him on Rybelsus about 1.5 years ago when it was launched. To my surprise, this patient, and he had continuous backache, he had already been operated in Ames for spinal surgery, but his pain was not going away with optimization of pregabalin. I'm just relating the related question. I put him on Rybelsus. This patient lost 23 kilograms on Rybelsus. His pain disappeared. His diabetes disappeared. And this patient says कि डॉक्टर साहब ये जो दवाइयाँ आपने दी सब बंद कर दो आप. And he has even stopped Rybelsus now after 18 months. And he continues to stay at that weight because he is so strongly motivated कि डॉक्टर साहब मुझे समझ में आ गया कि मेरी प्रॉब्लम तो वेट है. मुझे खाना ही नहीं है. Naresh also knows that patient. He is one of the patients here who has lost more than 20 kilograms on Rybelsus only. So you can now answer that question in that context.
So I totally agree. So these are all candidates. So anybody with a BMI of more than 30 or BMI with more than 27 with comorbidities, they're all candidates for semaglutide or other weight loss medicines. So there is no confusion about it. So these patients will all benefit from injectable semaglutide.
Dr. Tulsi sir.
Thank you, John. So, wonderful talks by Dr. Chawla and Dr. Bhattacharya. Enough compelling evidence to suggest that these drugs reduce cardiometabolic risk factors, they reduce weight, they reduce glycemia, they reduce MASH, they reduce fibrosis, and much more. They have neuroprotection as well effects. Renal outcomes are reduced, and UACR, as we know, is reduced, which is a marker of kidney health. And let us dwell a little beyond these. Of course, these are all off-label uses. I'm sure we are using it, at least I'm using it. The Turtle 1 study. Let's talk about the Turtle 1 study, sir.
So what is the question related to?
The Turtle 1 study. So use of GLP-1 agonist in the Turtle 1 study. So, okay, let me say this. Of course, this was an off-label use. It was used in type 1 diabetes. Mind you, there were no DKAs, no hyperglycemias, the use of these drugs, and what happened was that it reduced the requirement of insulin. Herein lies the hypothesis here that probably it increases insulin sensitivity. So these drugs may be tried, of course, they are off-label use. A few of the endocrinologists are using this in type 1 diabetes. You are not using anyway. Let me proceed further and talk about the recently, just a month back, the the European Academy of Dermatology talked about its usefulness in psoriasis. See, 78% reduction in premature deaths, 58% reduction in cardiovascular deaths. So increasing role in autoimmune disorders here as well because of its anti-inflammatory effects. Forget about obesity. And what else? I think that's about it. Anything else? I think that's about it.
The Turtle study?
Yeah, the Turtle. We already talked about
it. It is GLP-1 analog in type 1 diabetes.
It is the tirzepatide which was used in type 1 diabetes, and what did they achieve? They said there were no fear of DKAs. There were no fears of hypoglycemia. What it did was it reduced the requirement of insulin, and the hypothesis was that it increases insulin sensitivity.
Right. So just
there must be obese type 1. There are certain people
of course, they were obese.
Higher side agar sir hai.
Absolutely.
We've been using metformin also as an adjunct in people with type 1 diabetes. It reduces, of course, the insulin requirement because it enhances the insulin sensitivity.
Yes.
And I think that's a similar logic which
of course,
this
is off-label use, of course.
So the next question.
Okay, do you have some time?
Yes, sir. One more
question. So, tirzepatide outperformed Wegovy in the recently concluded ESC conference in respect of weight reduction. 21% versus 14% with Wegovy. On the other hand, a recent study also talked about better benefits, better cardiovascular benefits with Wegovy as compared to tirzepatide. So these are two, studies, observation studies. Thank you, sir. Talk us also about the STEERS study, which was an observation study recently published.
So again, so that is a gray area. So if you look, so there are comparisons of tirzepatide versus semaglutide, where both in obesity as well as in diabetes, weight reduction and the HbA1c reduction.
This was in non-diabetic.
No, so
the STEERS study.
STEERS is non-diabetic.
Yeah.
There is so again
also
there
the
are
select.
select is will be again in. So what we see is that in real world data, so there was 50% reduction in CV events compared to tirzepatide with injectable semaglutide. So that was from real world analysis.
That was a score trial. I think it was a score trial.
So that was, one is tier, one is score. So one is score was a comparison of tirzepatide versus semaglutide, where semaglutide
Yes.
did better than tirzepatide, and the steer was only semaglutide real world evidence, where also the risk reduction in CV outcome was quite well. And there are other trials from Norway and even other trials from European countries also, where the CV risk reduction is quite remarkable with semaglutide. So if you look into CV evidence, so if with the recent publication of the Surmount CVOT trial, and they have compared with dulaglutide, so it didn't do, actually it was comparable to dulaglutide. So even though dulaglutide is a molecule which has proven CV safety, but again, so they might have thought that they will be able to prove superiority over dulaglutide, which is a molecule with proven CV safety. They are not able to do it. They with a putative placebo concept, they said that okay, it has done better than actual placebo, but again, so that was not enough to get FDA approval for CV safety. So Wegovy has that, liraglutide has that. So if you ask about tirzepatide, in spite of the best of weight losses and best of HbA1c reduction, the CV safety data, including the real world data, even though the weight loss in the real world was comparable and even maybe slightly more with tirzepatide, but the CV risk reduction was more with actually Wegovy. So these are again gray areas. What is the role of GLP-1 molecules in the heart? What is the role of GLP-1 molecules in ASCVD? Whether addition of GIP actually has a negative impact or a positive impact? So these are all unanswered questions.
So when you're talking about ASCVD, the STOP trial said that reduces the progression of atherosclerosis. Not only that, it reduces the non-calcified plaque into calcified plaque, just as what the statins do, sir. Thank you.
Dr. H.L. Kantu sir has a question.
What about the risk of retinopathy with this GLP-1 agonist, semaglutide?
So, I mean the risk of the NION and is there a risk with GLP-1 analogs?
So again, so one is that of with semaglutide, there was a increase in risk of progression of PDR, but we have a dedicated focus trial which is going on. The results are going to be out soon.
The Indian trial?
No, that's a
international trial?
Multi-center international trial. So
okay.
We will have the results soon. So I think the results are going to be reassuring, and even with insulin also the retinopathy actually worsens, because any treatment which rapidly controls blood glucose will worsen the retinopathy. So that is the primary pathophysiology which has been proposed. So per se it should not be a problem. So but again we need to screen for retinopathy before starting this molecule. Right. So which is like a routine, not for obesity but for diabetes. Right. And for NEON the numbers are very, very less. So if you look into the prevalence of NEON in people with obesity, diabetes or hypertension, it's 0.02%. And if you look into the prevalence of NEON in with semaglutide in whatever trials we have, the numbers it's 0.04. So since the numbers are so less, unless we have a dedicated trial to analyze it, I don't think NEON is, the numbers are so less, so it should not deter patients from getting the benefits of this molecule. So PDR for diabetes you need to screen, obesity you don't need to screen, NEON, if somebody, you need to counsel about the side effects, but again should not be deterrent to start treatment.
Right, and whatever data you have, that is an observational data. There are no, it is not, it's not
so
a trial
again,
data.
the focus trial
there are
will
no
not,
RCTs.
No,
there
no
are no
RCTs.
RCTs. My last speaker pillar of the forum, Dr. M.L. Kalra said, to my two masters.
Sir, what a wonderful talk. two dashing personalities speaking about a new concept. My concept is, my two half questions are about, we have heard about good Taliban, bad Taliban, good cholesterol, bad cholesterol. Is there any good fat and bad fat? Are you losing bad fat or good fat during your process of losing weight?
So again, so that I partly alluded to that during my talk, that there is a concept of obesity paradox. So till the time the fat is in the subcutaneous tissue, so everybody has a threshold for subcutaneous tissue fat storage. So till that time, so the fat is healthy. So when that physiological limit is crossed, so when there is, then the fat starts becoming dysfunctional. So it starts secreting inflammatory mediators, it starts getting deposited into visceral adiposity increases, so it starts getting deposited in liver, pancreas, epicardial tissue. Even there are studies about kidney fat, and so all organs have some amount of fat, so it starts acting as a bad hormone.
So my point is, some people are now talking about Ozempic hip bumps and faces. What's